Hi, everyone. We'll get started in just a minute. Let people get into the room. Okay, I see it is 12:16, so let's not delay any further. Let's get started. Hi, everyone. My name is Jennifer Cunningham. I'm the Associate Vice President for Alumni Relations here in Bethlehem. I'm pretty excited because it's raining today, and tomorrow officially kicks off our reunion. So I'm glad that the sky is getting all the water out, and we're going to have a beautiful weekend for a reunion coming up. Hope to see a lot of you in person here. Anyway, I'm glad that you're joining us today for this webinar with Dr. Anand Ramamurthi. We're going to be talking about regenerating resilience for non-surgical tissue repair. Dr. Ramamurthi came to Lehigh in 2020. Before that, he was at Case Western Reserve in Cleveland at the Lerner College of Medicine, and he was also at the Cleveland Clinic there. So we're going to hear from him in just a minute. I just wanted to go over some choreography of these webinars. We hear from our speaker for about 15 to 20 minutes, and then we'll open it up for Q&A from you. And the way you'll do that is through the chat function. It's probably at the bottom of your screen. You just hit chat. And if you would like everyone to see your comments and questions, which I do encourage, make sure that that's selected in the menu. Otherwise, you can just send it to the hosts, and I will read all the questions out loud so that Dr. Ramamurthi does not have to pay attention to that. He can just focus on answering your questions. So with that, I'll turn it over. Let's begin.
Hello, everyone. I hope you can hear me. Thank you all for being here, and thank you again for the invite to present. So today we're going to be talking about regenerating resilience for non-surgical tissue repair. So what does this mean? So in a sense, what my lab does is to develop platform technologies and approaches to fulfill one of the major challenges that we have in the field of tissue repair, non-surgical tissue repair. That is the ability of adult tissues to regenerate or repair elastic matrix structures. These are the structures that allow tissues to stretch and recoil like a rubber band. So be it your lung, which expands to accommodate inhaled air, or blood vessels wherein the heart is pumping blood through, or even your skin. It's very flexible. So the big problem is that the component called the elastic matrix or elastic fibers, which allows the stretch and recoil, it post the development phase in the fetus, it does not really regenerate or repair if destroyed. So we are addressing this through various platform approaches. So to start off with, I'd like to talk a little bit about some of the fundamentals. I would like to bring up the term protease. Proteases are a family of enzymes, so to speak, which are capable of stimulating protein breakdown. So each protease is specific to one kind of protein. So they're very specific in their action, and they perform very important roles in the body, be it breakdown of proteins in food, degradation of pathogens. They help in blood coagulation. They also break down certain protein structures to produce mature forms of hormones and so forth. Despite these useful functions, they need to be regulated in the body. If they are in uncontrolled amounts, or if they are overexpressed or not kept in check, then they can break down tissue structures, which lead to various forms of disorders, which are known as proteolytic disorders, wherein the tissue structure breaks down and the tissue function is compromised. Examples: chronic obstructive pulmonary disease in the lungs, aortic aneurysms where there are bulges in the major blood vessel, the aorta, pelvic organ prolapse, which can be vaginal prolapse or bladder prolapse, where there's these organs which are supported by tissues. The tissues break down, are weakened, and then these organs actually extrude out of the body. And inflammatory bowel disorders, etc. So one of the proteolytic disorders that we are actually targeting, and specifically to regenerate the elastic matrix to alleviate these conditions, are abdominal aortic aneurysms, or AAAs. So these are basically localized bulges of the major blood vessel, the aorta, between where it splits to supply the kidneys with blood, and where you have the iliac bifurcation at the bottom. So this, in the abdominal area, it's called the abdominal aortic aneurysm. So what happens is that there's some kind of injury to the blood vessel wall. You have inflammatory cells move in, they produce, overexpress these proteases, they break down the wall elastic matrix structure, wall weakens, thins out, and then balloons and ruptures fatally. These conditions afflict primarily men, elderly males who are particularly smokers are at high risk, chronic smokers, and they are very fatal at a very late stage. But they're very, very slow growing conditions. You know, a person might have had an aneurysm for 10 years without a symptom, without the aneurysm even growing. In others, it can grow rapidly and then just stabilize. And others, it just ruptures. So these are very varied set of conditions. But interestingly, there are no non-surgical treatments for these conditions, and surgery is pretty much performed only at a very late stage when risk of rupture is high, such that risk of rupture is higher than risk of surgery itself. And there are no ways to actually reverse this condition. So before I get into our approach to actually developing such a strategy for non-surgical repair, let's just look at how the aorta wall is structured. You know, you have these within the aorta wall. If this is a cross section, you will see these concentric layers. Those are the elastic fibers or elastic lamellae, so to speak. And what they help in doing is when the heart actually pumps out blood, they, like a garden hose, it balloons to accommodate that blood flow. And then when the heart is actually filling with blood and not actually pumping, these snap back and then propel the blood forward. So it maintains the blood pressure. So there's a mechanical role there for the elastin. In addition, you have, if you look at this figure here, you have the green squiggly lines. Those are the elastic fibers or elastic lamellae. And in between, you have the pink stuff, which are smooth muscle cells, which are in contact with these intact elastic fibers. So what it does, the elastic fibers signal the smooth muscle cells and tell them, do not multiply, do not form an atherosclerotic plaque by over multiplying. Right. They also control how much calcium gets into the tissues and therefore prevent the tissues from hardening, prevent arteriosclerosis. So the elastin performs a very important role, the elastic fibers and its component protein known as the elastin. It performs a very important mechanical as well as a biochemical role. So its breakdown has adverse outcomes, as we'll see right now. So if you look at abdominal aortic aneurysm, how does it actually develop? You see there is an initial injury to the vessel wall, which could be like smoking or chronic hypertension or any such reason. You have a recruitment of inflammatory cells, white blood cells. They overproduce these proteases, and that causes breakdown of the elastic matrix, and the vessel loses its elasticity and balloons. Right, because of that ballooning, the vessel tries to compensate, so it produces a little bit more collagen, which stiffens the vessel wall. Right, and that is why the aneurysm doesn't rupture immediately. It's kind of stabilized for a moment, but later the collagen also gets broken down and the vessel ruptures. So where I'm getting at is if we manage to prevent breakdown of the elastic matrix early on and also regenerate or repair those fibers which are broken down at an early stage, then we have a prospect for early repair of the aneurysm and prevent it from growing further. So let's talk about elastin and what the challenges are in such regeneration. So if you look at this figure here, this shows how as we age, the quality of our skin deteriorates, right? It loses its elasticity. And that's a physical manifestation of elastin degradation over time. This happens due to internal chronological changes and external environmental factors. But it is a very slow process because this is a protein, the elastin protein, which makes up the elastic fibers. It is extremely highly cross-linked, and it is also hydrophobic, which means water hating. So in a aqueous environment, fluid environment like our body is, it's very stable. It doesn't break down. So it lasts for like 70, 80 years as its half-life. So if you look at the interesting things about elastin or elastic fibers, is most of it is produced just before or just after birth. So you see the top images here on the left, it's in the fetus, the elastic fiber is forming. And by the time a person is around 10 years, you see it's really dark, which means it's really matured elastic fiber. Right. And after that, it remains pretty stable across the lifetime of an individual. And by the time a person is around 70, 80 years of age, then slow degradation occurs in regions. But that's not cause for concern. It's mostly intact in most parts of the body. At the same time, in past the fetal stage, in adults, there's a buildup of sex hormones such as testosterone and their byproducts. And what they do is to shut down the elastin gene expression. And therefore, the elastin protein or elastic fibers are no longer formed, or they're not preferably formed in adult tissues. And even more, it's even worse in diseased tissues, right? So how do we restore tissue elasticity? So let's say in an aneurysm, you have breakdown of elastin in the wall. How do you replace that or restore the wall vessel elasticity? There are three major approaches. One being matrix preservation. You use some kind of drugs or agents to inhibit or block those enzymes which cause breakdown of the elastic matrix. But you will realize you can't replace what has been already lost. The second approach is matrix replacement. A number of research groups have actually developed this synthetic polymers, which have the same mechanical properties and same stretch properties as native elastic fibers, right? That's all great. But then what about the biological function? They influence cells. Elastic matrix influences cells as well and keeps them from being diseased. So that these polymers cannot accomplish. So which leaves us with trying to regenerate or repair the matrix using the diseased cells themselves. But the big challenge here is that the cells do not produce elastin, are incapable of producing elastic fibers in adulthood. And that's a major challenge that we have taken upon ourselves. So this is a very complex slide, but it shows how basically the elastic fiber assembly process, it's a very complex multi-step process. But this also, what I wanted to emphasize through this is that there are many, many opportunities for us by targeting one or more of these steps to actually regenerate or repair the elastic matrix. And that is what we are doing. So how do we study our elastic matrix regenerative therapies? Where do we study them? We study them in small animal models such as rats and mice, and we also study them in cultures of cells that are obtained from the simulated aneurysms. So this is an example of an elastase injury rat AAA model, and where we actually expose the aorta in the animal under anesthesia. We stop the flow, we inject an elastase, allow the vessel to balloon, it breaks down the elastic matrix. And over a period of 3 weeks afterwards, that injury has caused inflammation and causes a big aneurysm to develop, a big expansion. And we have shown that the elastin is completely lost. The red stuff is completely lost over the period of time. We have used MRI to show that the vessel is actually expanded, diameter has become bigger, right? And so these aneurysms are useful to test our therapies and to obtain cells to test our therapies on. So we've been working with a number of drugs. One of them is called doxycycline, which is a common antibiotic and is also an inhibitor of some of these proteases that we talked about. And it's been orally given to AAA patients, and in some cases, it's been shown to slow aneurysm growth. But what we have seminally found is that if you take these clinical doses and decrease the dose maybe 100-fold below the clinically acceptable oral dose, this drug actually has new effects, and that effect being stimulation of elastic matrix and elastic fiber formation, which is a completely new result, and it continues to also inhibit the enzymes that break down the elastic matrix. So two great benefits. And we have looked into the mechanisms of this and identified that the doxycycline actually inhibits something called a protein within the cell called the JNK protein, right? And by doing that, it stimulates elastic fiber formation. It also inhibits breakdown, protease-mediated breakdown of elastic matrix. We have also been looking at repurposing of a cancer drug, right, which is called afatinib. which is an EGFR or epidermal growth factor receptor inhibitor. So this is a typical cancer drug, but we have actually shown that when you treat the aneurysmal cells with these drugs, on the left you see a frustrated elastic fiber formation. So all the gray stuff here, you see it's not a mature fiber. But if on the right side, you see it's treated with afatinib, you see how much matrix is present, right? All the dark stuff, and it's forming these nice fibers and so forth. So that's a real a cool outcome. So in order to deliver these effects, I should emphasize, are very specific to dose. So you need to deliver it at a very specific low dose to get these effects. And for that purpose, just giving it these drugs orally will not do, because it gets distributed throughout the body, has side effects, and you don't know in the aneurysm site whether you are actually seeing that dose that you need to obtain. So we have been looking at ways to actually deliver these drugs at low doses in a localized delivery to the abdominal aortic aneurysm wall using nanoparticles, which are typically particles, polymer particles between 10 to 100 nanometers. They can be used to deliver a variety of active agents. They can be drugs, they can be genes, gene silencing agents, small interfering RNAs, biologics, diagnostics, etc. And some of the advantages they have is that you can target them to the tissue where you want them to go to. You can reduce the dosing frequency so they can stick to the tissue and then release the drug over a period of time, so you don't have to keep taking the drug. You can avoid side effects, body-wide side effects, and so forth. So we have developed some multifunctional nanoparticles for elastin regeneration in AAAs. I'm not going to go into this in depth, but what we have done is modify the surface of the drug within the nanoparticle. These are based on polylactic co-glycolic acid. We incorporate our drug of choice, afatinib or doxycycline within these. They get released as the nanoparticle degrades in an aqueous environment within the tissue. On the surface of the nanoparticle, we have incorporated some cationic amphifields, which means they have a positive charge, which helps to get them into the vessel. They have a positive charge, which actually engages with those proteases and inactivates them, because a positive charge does that. And they also have a hydrocarbon chain, which means that it is hydrophobic and it allows it to bind to the elastin, degraded elastin in the tissue, and therefore remain there to actually regenerate, release the drug to regenerate the elastic matrix. We have used the same kind of nanoparticles to actually also release small interfering RNAs or siRNAs. So I told you the doxycycline inhibits the JNK protein, and that is responsible for all its therapeutic effects. So instead of inhibiting a protein, which is not a complete inhibition, it's only down regulation or you decrease its activity, can we be more effective by inhibiting the gene itself, which is coding for that GNK? And so we're using small interfering RNAs released from these nanoparticles, which inhibit that gene, and that causes the protein not to be produced at all, right? And so you see some transmission electron microscopy images here. On the top row, top left, you see no treatment. You see frustrated fiber formation. And then when you treat it with the JNK2 siRNA, you inhibit the JNK2 gene, you see these clumps of elastin forming into a fiber here. And bottom middle, you see a mature fiber, a thick band fiber, which you see with the siRNA treatment. So this is some of the advantages that we have. So moving on, we realized that if we're trying to really get away from surgery, the easiest way to deliver any kind of nanoparticle treatment is intravenously. So it can be done under outpatient conditions by a nurse practitioner, a trained nurse practitioner. So you inject it through the the vein in your arm, and the issue is that nanoparticle delivery to the abdominal aortic aneurysm is not very efficient, right? Once you inject it intravenously, it goes through the lungs, and a majority of the nanoparticles get filtered out in the lung blood circulation. right, in the blood vessels of the lung. And then as it gets into the aorta, it's in a very high flow environment, and very little actually managed to stick to the aneurysm wall. So if you see this plot over here, we did a kind of a study in one of these aneurysm models in rats, and we show that majority of it gets into the lungs or the liver, right? And so it is not very efficient. So for this purpose, what we did was we modified, instead of passively targeting the nanoparticle, that is allowing it to go and stick on its own, get into the tissue on its own, we incorporate certain moieties on the surface. Maybe it's an antibody, sometimes it's a small protein fragment, something that recognizes a protein or protease that is really overexpressed only in the aneurysm site. So when it sees that at the aneurysm site, it'll go bind there and stick there and then release the drug from there. So we realized that we found out that there's a protease called cathepsin K. Okay, it's an enzyme which is overexpressed only in the aneurysm wall. We have shown here the orange fluorescence here and in the vessel itself, right? And but not in a regular remaining part of the aorta. And we have developed these nanoparticles which incorporate either antibodies or these protein fragments. And we have actually shown that it allows the nanoparticles to stay on and stick on inside the vessel where they wouldn't be otherwise, and preferably get into the cells. As you see in this, the red fluorescence, that's the nanoparticle getting into the cell. Without that peptide on the surface of the nanoparticles don't get in very much into the cells. And then they are able to stay in long term within the blood vessel wall. So it's a green nanoparticles here, right? It gets in through a thrombus within the blood into the aneurysm segment and gets into the wall. So it stays there for several weeks. So that is all very exciting. So in the last two slides, I'd like to just shift gears a little bit. So in this nanoparticle work, we are at the stage of actually doing some efficacy studies, looking at therapeutic effects now in our animal models. And in separate projects, we have been looking at the benefits of stem cells derived from patients, from bone marrow mesenchymal stem cells, which are adult stem cells, not embryonic. So we have shown that they actually produce a lot more elastin and are useful for elastin regeneration compared to diseased aortal cells. So what we have shown is that when you deliver these stem cells or variants thereof into the aneurysm, they actually prevent aneurysm growth. So in these are MRI reconstructions. So in all these panels, the first image represents the healthy aorta, right? And then the second image represents when we induce an aneurysm after 3 weeks, it's a little bigger, okay, than the healthy aorta. And then when we introduce either the stem cells in the first two groups, or just we put saline, right, without any cells. And you see in the saline control, which are a non-treated group, the aneurysm continues to grow and you have a big fat aneurysm at the end of it. Whereas the aorta actually reverts in size and becomes smaller, again, with the stem cell treatment, which tells us the stem cells are useful for this purpose, even though they're not very efficient at getting into the aneurysm wall. And we were able to show that the matrix are also repaired compared to similar to the healthy control. So moving ahead, we have determined that these stem cells, their physical presence, they're not very efficient in going into the aneurysm wall. And their form also changes when you incorporate them into a diseased patient. So we have determined that the physical presence of the stem cells itself is not important. Rather, the cells secrete some biological factors. They generate some biological factors which tell the disease cells to repair, right? And so we have determined what are these factors. So they produce something called extracellular vesicles, or EVs, which are capable of signaling the disease cells to produce new elastic matrix and repair the old ones. So what we're doing is culturing the cells, stem cells, extracting these EVs, characterizing them, purifying them, and then injecting these EVs, which are obtained from the stem cells, into the aneurysms, right? So that we have a stem cell inspired but cell-free approach to regeneration. So that is ongoing. We have published a little bit on that. So on that note, I'm going to be ending. I'd like to acknowledge some of our funding sources, our great team of students and research faculty, and many of our collaborators. Thank you so much for your attention. Happy to take questions.
Fantastic. Thank you, Anand. We do have a couple questions. Sorry, my screen just. Okay. So David was asking about, it was back a few minutes ago. Are these results typical of other TKIs?
Could you repeat the question?
He was asking, are these results typical of other TKIs? And I'm not sure. That was at about 12:30. So about halfway through your presentation, you were talking.
Okay. I'm not really sure what he means by TKIs. If you could expound a little bit, we get back to that.
David, why don't you type in a little bit more about that question? We'll go to Phil's question.
Oh, it's probably tyrosine kinase inhibitors.
Oh, okay.
Yes. Yes, absolutely. Yeah, these are quite different from that. And as I said, these are drugs which have been repurposed, right? So for example, doxycycline, this is a common antibiotic, and we're using it for elastin regeneration. Similarly, the afatinib is a epidermal growth factor receptor inhibitor, which is commonly used to stop proliferation and kill cancer cells, tumor cells. So we have found a new use for it at a different dose range. So yes, but they are quite different from the TKIs. Yes.
And then Phil's question is kind of similar to that. These are seriously off-label applications of these medications. How do you decide to study their effects with AAA issues?
Yeah. So this is a long process. So for example, doxycycline is not completely new in the aneurysm context. It's been a number of trials have been done on small animals, large animals, as well as in clinical patients. As I said, it's delivered orally, and the primary known effect was to inhibit those proteases and so in some cases they saw a slowed aneurysm growth. What we have demonstrated, in fact, at those high doses that are clinically delivered, right, prophylactically, those high doses actually inhibit elastic matrix production, which worsens the condition, right? So there's no prospect for regeneration or repair. We have shown same drug reduce the dose multifold, right? And then at 1/100th of the dose, it actually continues to inhibit those proteases, but at the same time, it stimulates elastic matrix regeneration, which is an added benefit. And so the only thing is we have to use it locally instead of systemically. We have to deliver it locally so you can maintain that low dose. So it's not a completely off the beaten path kind of approach. It is you take an existing drug and reutilize it. Now, on the other hand, after this is a completely there has been some limited work done on epidermal growth factor and its relation in aneurysms, but our group is the first one that has shown that similar to cancer, not exactly the same, but the same kind of pathways are also involved in aneurysms, and we can leverage that to stimulate elastin production. And so it is certainly new in the context of aneurysms. And so it is a significant amount of in vitro testing, continued in vitro testing, as well as studies in animals, validation in animals is required before we can take it further.
And I'm going to jump down to a question that Gordon has because he's talking about, he says, if I understand, your research involves introducing very low dose doxy, which you just said, using mRNA as the delivery system. Is that correct? And was this possible before COVID-19?
Okay, so first of all, you're right in the sense that, David, you're right in the sense that we are trying to deliver very low amounts of doxycycline. Okay, there's another drug called doxorubicin. People tend to interchangeably use the word doxy. So I need to clarify that this is doxycycline. Doxorubicin is more of a cancer application, right? But in any case, yes, low dose delivery. But we are not using mRNAs. mRNAs are called messenger RNAs, and they are used to actually stimulate certain expression of certain genes, right? On the other hand, small interfering RNAs or siRNAs, they are used to inhibit. They actually, within the cell, they bind and inactivate the messenger RNA. So basically, gene expression for a particular protein, you can selectively inhibit it, attenuate it, or inhibit it completely, right? And so small interfering RNAs are what we use, not mRNAs. Just to clarify.
Okay. Phil says, fascinating research. Tall, skinny males are the highest risk for triple A's. So it's personally interesting. And I want to follow on that. Is that true that skinny males are at the highest risk, and why? And if
Okay,
a
so
skinny, if it's true, can skinny males get fat and then not have such a risk?
yeah, we'll throw in another parameter, skinny Caucasian males, right? Yeah,
Well,
but older Caucasian men are particularly at high risk, right? That's a known fact, and that's why, Medicare approves these proactive screenings, ultrasound-based screenings and so forth, where they first detect these aneurysms. But to your point, it is not a completely random occurrence, that observation that tall, skinny men can tend to have aneurysms, because a subset of these abdominal aortic aneurysms, let me rephrase here. Aortic aneurysms can be of two kinds. Okay, one are the thoracic aortic aneurysms, which occur closer to the heart, and then the abdominal aortic aneurysms, which are in the abdominal aorta, right, below the kidneys, right? There is subtle differences, actually some major differences. Thoracic aortic aneurysms are typically associated with genetic conditions, syndromes, genetic abnormalities. For example, there is the William Bueller syndrome. There is there's something called SVAS. And then Marfan syndrome, right? So Marfan syndrome is a connective tissue disorder. And many of the patients you see, they have the typical skeletal structure, tall skeletal structure. They have mitral valve prolapse, so they have defective heart valves. It's a set of conditions that come with the genetic abnormality, right? And it's associated with abnormal TGF beta signaling. And so that is a genetic condition. Now, abdominal aortic aneurysms tend to be slightly different because they are acquired rather than genetic. Although a small subset, maybe like 10 to 15%, could have a genetic basis, majority of them acquired. It's due to chronic hypertension or smoking or chronic smoking and things like that, acquired disorders. So it tends to be more of an inflammatory disorder rather than a genetic disorder. But coming back to the point here, so there is a common, so often you might have men are more susceptible. They tend to have there are a subset of men who tend to have connective tissue disorders such as Marfan syndrome, where they have this tall skeletal structure as well. And many of those patients actually, one of the manifestation of the syndrome are thoracic aortic aneurysms, or in a small subset of cases, abdominal aortic aneurysms. So that's the association that I can see here.
David says this is very cool. What do you think is the mechanism for the nanoparticle entering the cell? Is it normal receptor turnover?
Right. So what we have actually shown is that it is not receptor mediated in the absence of a cathepsin K binding protein, which is what we put on the surface of the nanoparticle. So it targets the cathepsin K, which is expressed on the surface of these cells. But if you're doing just passive targeting, it is basically just attaching through it has a positive charge which binds to the negatively charged entities on the surface of the cell, right? And then basically through invagination of the cell membrane, it just envelopes it into the cell. So it's not receptor mediated in the absence of any specific peptide. But if you put a peptide on there, it is receptor mediated. Yes.
A few people have questions that are sort of related, asking about other applications. So John asks about applications in musculoskeletal conditions. Another about improving burn scar contractures. Someone else asking about cranial congenital aneurysms. So can you talk
Yes.
a little bit about how this may apply to other conditions?
Absolutely. So there are applications associated with these nanoparticles. These are not the only kind of nanoparticles. We ourselves work with a variety of different nanoparticles, right from liposomes to polymer-based and everything in between. And they're also used for diagnostic purposes or therapeutic purposes, ablation, and et cetera, et cetera. So yes, these nanoparticles could be utilized in those settings as well. Cranial aneurysms are slightly different. Um, uh, you know, the blood vessels in the brain, right? Those are much smaller and they don't really have a thick elastic matrix. They're not really elastic. Uh, so, so the mechanisms of them being leaky, right? When they become leaky, their wall tends to be 1 or 2 cells thick. So when it becomes leaky, that's when you have, you know, it becomes an issue. But so we expect that these nanoparticles or variants thereof can be useful in that setting as well. But the outcomes that we would be looking for would be different in the sense that we're not particularly looking to regenerate elastic matrix. Rather, we'll be looking at some other outcome. It can be similarly applied to various musculoskeletal disorders, certainly for cosmetic purposes. That's one of the easier things to do because it's topical application. It's topical application on the skin. It's not considered invasive. So, it's easier from the standpoint of translating it. It's considered a cosmetic and not a therapeutic. Um, uh, yes, absolutely. Absolutely. And we have done some work with fibroblasts, dermal fibroblasts, and shown similar kind of benefits there too. There are other applications we are working on, which I did not talk about today. There are way too many projects. But in the past, we have worked on chronic obstructive pulmonary disease, COPD patients. And COPD patients who have COPD secondary to lung tumors. So when they have lung tumors, there's normal lung tissue around the tumors. And what happens is that many of those patients also have COPD, so that elastic matrix actually breaks down. So when it breaks down, the respiratory capacity decreases. So more so when they resect that part of the tumor, they cut the tumor off, that tumor is part of the lung, which means the lung is becoming smaller. And already you have reduced respiratory capacity. So it is a problem. So what we're trying to do is actually regenerate or repair the elastic matrix in the non-tumorous lung tissue, which is subject to COPD. Therefore, we believe it will also make anti-cancer therapies more efficacious, right? So that's one thing we have worked in the past. We are also actively working with a collaborator at the Cleveland Clinic on regenerative therapies for pelvic organ prolapse in women. Particularly in postmenopausal women, right? So after repeat vaginal childbirth, you have the weakening of the pelvic floor muscles and the vaginal tissue start extruding, right? Which is very painful. So they use meshes right now to surgically hold it up to provide support. And those meshes are too stiff. So basically they have been removed from the market because they cause stiffening and thickening of the tissue, very painful. So there's no alternative, right? So we're looking at regenerative therapies where we inject the nanoparticles into the vaginal wall and it repairs the elastic matrix and makes it more pliable, right? So we're working in very nice interesting mouse models on that project as well. So there are certainly a lot of other applications. The limitation is the people power and the the funds to carry out all that we are interested in. Yeah.
Quick question about, would you be okay sharing the slides with
Absolutely.
people?
Absolutely.
Okay.
Absolutely.
All right.
Yeah.
We will send those out. And John would like to connect with you afterwards. He's an orthopedic surgeon.
Superb. Look forward to it.
Yes. Jean has a question about how the therapist would recognize that these technologies would be beneficial for a specific patient. So is it an MRI? What is is a blood test? How do
Mhm.
they
So
determine this?
this is a very interesting question, and it's not an easy question to answer, right? But we are trying to address this. What we have done is we have developed an archive. We have set up an archive of human aneurysmal tissues from patients undergoing aneurysm surgery, both men and women. We have got information on, patient de-identified information, such as age of the patient, gender, um, well, whether what the size of the aneurysm was at the time of surgery, whether there was a thrombus or not, are they under statin therapy, are they smokers, ex-smokers, heavy smokers categorized, right? So we try to get all that information. And then what we did with the tissues is we did a lot of histology on the tissues and to look at the elastic matrix and the wall, right? And what we are and we have developed a kind of a imaging based algorithm to look at various characteristics of elastic fibers in those aneurysm walls, right? So what we're trying to do now is put all that data together and use kind of machine learning techniques. And we are kind of new to this area, so it's a learning process for us too. Use kind of machine learning techniques to take all this data and look for trends. So if the aneurysm has a thrombus, is the elastin in a worse shape? Is the elastic fiber more tortuous or less tortuous, or it's fragmented, or the amount of elastin is reduced? How does it correlate with this? And what we want to get out of this is to identify what is the best stage for intervention. Is it when the aneurysm is 4.5 centimeters? Or is it when it's 5.5 centimeters with a thrombus, or 4.5 centimeters with a thrombus? In that case, it's better to intervene because the elastin would be gone at that stage or soon to be gone, right? We're trying to personalize this a little bit more. We are quite far off from where we want to be, but we have initiated this already. But that's a fabulous question, and that would really provide a kind of a guidance to clinicians to determine exactly when to intervene and which cases to intervene in.
Right. Eliana's asking a question. You're talking, that the heart disease mostly affects men, but she's asking, could this be helpful to regeneration of elasticity of joints, soft tissues, and tendons due to the loss of estrogen in menopause? In which case I'll pile on and say, do you think about the differences in the genders when you're testing?
Absolutely. Absolutely. I'm so glad you asked that question. We actually we have a new doctoral student from Nigeria. His name is Ali Muta, and he just got a fellowship from the American Heart Association to study exactly this, to look at, and this is a direction we have just initiated this with this project with him. And we're looking at, we know that estrogen is kind of a protector against heart disease and certainly aneurysms. And it's been shown, for example, you have female mice or rats, and we do an ovaryectomy, which means you remove the ovaries, right? These are young females, and you remove the ovaries, and you see that the aneurysms, if you try and simulate the aneurysms, they grow as much as or more than in the male animals, right? On the other hand, if you take estrogen and deliver to male animals, okay, which in which you have simulated the aneurysm, right? The aneurysms grow much slower, or they actually reverse themselves, right? So there are some very interesting trends here which tells about the protective role of estrogen. At the same time, estrogen therapy, systemic estrogen therapy in men is not advisable. It has a lot of other side effects as well. You don't mess around with hormones. So using nanoparticles to locally deliver, that would be a great idea. But at the same time, this is why in our animal models, we never use female rats. Why? Because they never develop aneurysms. Even when you try to stimulate that, they don't develop aneurysms, which means that they're kind of protected. So we're looking at other models where, okay, so to go back a little bit, it also emphasizes why heart disease is much more prevalent in postmenopausal women, but is inadequately studied. It's not even recognized, right? So it tells you something. When the estrogen level goes up, the risk factor goes up. The risk goes up, but it's still seen as a male disease, right? Heart disease is seen as a male disease, but there are women who catastrophically die even for small aneurysms. They don't even have to grow to the 3 times its size. Even when it's still small, 4.5 centimeters, it might rupture for females, postmenopausal females. So what we're trying to do is identify what the effect of estrogen is. How can we deliver this in a systematic way? How does it impact the elastin regeneration, and how it can be applied in this demographic segment as well? Yeah, very important question.
Yes, I'm glad that she asked that.
Yes.
Well, it is 1 o'clock and our time here is over. That went really quickly. And we have a lot of people, I think, really interested in your research and perhaps eager to get in touch afterwards. So is it okay if we give out your email? And okay,
Absolutely.
fantastic.
Anytime. Thank you so much
Okay.
all for being here. Yes.
Yes, thank you all. Thank you,
Bye-bye.
Dr. Ramamurthy. Bye-bye.